Okay, very good evening, all the participants and members of the floor. It's a great honor for me to present as the first participant today. Now, this is the first time I'm doing this. It's kind of awkward for me. I try to make myself comfortable here, but I would like to share with you one of my research done about 1 year ago. The title of the article is Prevalence of Antenatal Depressive Symptoms and Associated Clinical and Health Risk Factors among Pregnant Women with Previous Miscarriage in Kuching. Now, Kuching is a very small city in Malaysia here, but it's the capital of Borneo. Okay. Now, as we all know, pregnancy is a God-given life events which especially for women, and any loss of the pregnancy itself is very traumatic and tragic for everyone, including the whole family. Now, women with previous miscarriage seems to have poorer quality of life during subsequent pregnancy. This is what we observe usually in clinical settings. Now, maternal morbidity and mortality itself reflects the healthcare standard of a country. So this is an initiative we would like to do to look into the mental health of the women with previous miscarriage. Now, these are the theoretical framework that we have figured out before conducting this research. Now, anyone with previous miscarriage, if he or she was going to develop into subsequent antenatal depressive symptoms, we might need to look at different factors. Now, these are the 4 factors that we come out, which might be the risk factors that develop into the subsequent antenatal depressions, especially in the pregnancy, subsequent pregnancy. The 4 factors is health characteristics, clinical characteristics, psychosocial impacts, and social demographic characteristics. Health characteristics that we identify in this research, including history of alcohol usage, history of illicit drug usage, pre-existing medical conditions before pregnancy, frequency of exercise, frequency of meal patterns, and durations of the sleep. And whereas clinical characteristics includes numbers of miscarriage, durations of last miscarriage, presence of previous antenatal depressions, any procedure done before, and family history of miscarriage. And psychosocial impacts that we're talking about is there any strict adherence to cultural practice during confinement period? Any family taboo on the miscarriage, and any presence of constant worries during current pregnancies, and any guilty feelings of previous miscarriage, feelings of supported from husband, staying with in-law, or satisfaction with marital relationship. The last one is about social demography. What we are looking at is age, race, place of origins, educational level, number of living children, occupations, religions, income, marital status during the pregnancy, and how many years of marriage. There are certain factors which prevails as risk for development of depressive episodes, which we know, especially previous miscarriage. This is what we want to look at in this study. So there are some study showing that previous miscarriage may cause later on there is antenatal depressive symptoms, usually in China, in Australia. But we would like to know whether the result is replicable in our context, especially in Malaysia. And is there any other risk factor? And before setting out this study, we're actually particularly looking at any cultural factors. You all know that different races, different countries have different cultural, so we might need to look at whether Borneo have different culture, which might contribute to the next antenatal depressive symptoms. We also consider whether there are possibility of biomarkers to diagnose depressions in future, especially if we're looking at the sleep patterns, the meal patterns, which is involving the hormones responsible for the antenatal depressive symptoms. So that we're looking at whether there is possibility of biomarkers next time to diagnose. The research questions we are looking at is aims to find out whether citizens in Kuching experience depression during antenatal period following previous miscarriage, and we would like to know what is the prevalence of it, and is there any possible risk factor as well as protective factors that might help us in a clinical judgment. The methodology we are using is a cross-sectional study of pregnant women with previous miscarriage. We're adopting 8 government health clinics as well as maternal and child health service in Kuching. We're adopting 3 urbanized clinics and 5 suburban samples. The reason we would like to choosing whether it's urban or suburban because of the distribution of the races itself. There are some, especially in Chinese, is more concentrating in the city area, and others races like Malays and Bidayuh is more to the suburban area. So we would like to have proportionate samples chosen. Now, all women visiting those clinics will be included. The inclusion criteria is adult women who are attending the clinics for their routine antenatal care regardless of their gestational age. The subject's age is between 18 to 45 years old, and they must have history of miscarriage or induced abortion. The subjects are literate in Malay or English or Chinese, and they consented for the study. The exclusion criteria include adult mother who is illiterate or unwell to participate will be excluded. Those who refuse consent, and those who have pre-existing mental illness before pregnancy. These were all done through the review and antenatal clinic cards cover. We actually cover every pregnant mother will bring a small antenatal card, which will in the front page it will stated how the general any pre-existing mental illness or pre-existing medical conditions. So we were using color coding for that as well. So the questionnaire is a self-administrated with no time limit with information sheet included. Those questionnaires include social demographic data, relevant clinical and health characteristics, and also Edinburgh postnatal depression scales. Besides univariate study, stepwise linear regression analysis will be applied to ascertain the risk factors of the depression in a woman with previous miscarriage or abortions. These are the results. We actually recruited 150 pregnant ladies who fulfill the inclusion criteria, and 22% score more than 11.5 in EPDS. So it means the prevalence is about 22%. It was a significant protective factor as non-professional and non-strict adherence to cultural practice during confinement periods. Okay? These are the protecting factors that we found. And there were 5 significant risk factors identified. There was strict adherence to cultural practice during confinement period. The likelihood ratio is about 5.8. So the other risk factor is planned pregnancy. Likelihood ratio is about 5.2. And for those who are not staying with the in-law, the risk is higher. So the odd ratio is about 3 times. And for those who are taking less than 3 meals a day, likelihood ratio is about 40. That's a lot. And those who sleep less than 5 hours a night will pose them a likelihood risk of about 15.8. And from the 5 risk factors that we identify, 4 of them consider independent risk factor after we tested with Pearson two-tail. The 4 independent risk factor is strict adherence to cultural practice during confinement period, not stay. Let's discuss about these results. If we compare the results with the similar studies done in China, Jordan, Nigeria, Sri Lanka, Ethiopia, Oman, the prevalence we get from those studies range from 16.2 to 28%, which is roughly correlating. So all the studies mentioned above without inclusion criteria of previous miscarriage, therefore technically is incomparable. So in this study, the effect of miscarriage might not be significant, therefore the prevalence was just the reflective of general population. Nevertheless, this conclusion was crude on the basis of inadequate sample size. So some studies show unplanned pregnancy was one of the risk factors of antenatal depressions, which were contrary with the finding. Evidence that does show that social support as a protecting factors. Now, this interestingly, we found that with staying with in-law, the issue might be handled better because we need culturally, we usually depends on the family for the help of the child rearing. So there are also significant relationship between sleep quality with prenatal mood disorder. Otherwise, did not find any literature about the culture. So this is the new things here. So summary, previous miscarriage increased chances of developing depressive symptoms during subsequent pregnancy, and study aims to look at all these. So results shows about 22% of antenatal depressive symptoms with history of miscarriage. Occupational as professional, non-professional and non-strict adherence as a protective factor, and planned pregnancy was found to be significant risk factor. So new protective factors and risk factor was demonstrated. So psychosocially, the study discovered the role of strict adherence to cultural practice during confinement, not staying in law, and as professional as significant risk factor. So there's a mistake there. And surprised to find that planned pregnancy posed higher risk of antenatal depressive symptoms, which was contrary with other many studies. Biologically, sleep and the frequency of meal play an important role. So limitation is recall bias and selection bias, poor generalizability, sample size was too small, therefore there's inadequate statistical power for decision making, and the time for the research is actually quite short.